welcome to everyone. In today's virtual conference on updates in lung and liver cancers. It is my pleasure to extend heartfelt greetings to all our esteemed faculty, residents, and delegates from across the country. Today's session brings together leading mindsets in oncology to share the latest advancements, evolving treatment strategies, and multidisciplinary approaches that continue to shape the landscape of lung and liver cancer. We hope this evening will be both informative and inspiring, sparking meaningful discussions and collaborations in our shared mission to improve cancer care outcomes. Without further ado, let's begin the session and invite our first speaker, Dr. Shrikant Boga. He's a senior consultant medical oncologist at Omega Hospitals, Vijayawada. Welcome, sir.
Yeah, very good evening, one and all, and uh, thank you for Roche Oncology for giving this opportunity, and respected seniors and my dear colleagues, and welcome to one and all. And today, I would like to share my screen. Yeah. Just anybody give a confirmation, and my screen is visible, and I am audible.
Yes, sir.
Yeah. And today I will be presenting a data from Kerala multicentric real-world study on the combination of atezolizumab and bevacizumab in unresectable hepatocellular carcinoma. And particularly, this is a collaborative effort between the Amrita Institute and Aster Medicity, and which was recently published in the BMC Cancer 2025. And these are the slides which are provided by Roche Oncology. And if you look at the data gaps in hepatocellular carcinoma, as we know, there are landmark trials in HCC, often include several real-world subgroups, which include the thrombocytopenia, co-infection of both HBV and HCV, and history of bleeding, fibrolamellar HCC, and autoimmune disorders, and mixed HCC and CCC, and HIV positivity, and elderly population. So this leaves a significant evidence gaps. So the real-world data is therefore very crucial to understand the treatment outcomes in this particular underrepresented populations. So still the randomized control trials are remain gold standard, and they are limited by strict eligibility criteria. Real world evidence complements the RCT by including the patients we actually see in the routine oncology practice, older and comorbid previously treated cases, and providing insights day-to-day clinical effectiveness and tolerability. Coming to the IMBRAVE 154 study, this is the registration trial, and which is established atezolizumab and bevacizumab as the new first-line standard in the unresectable hepatocellular carcinoma, and the combination is achieved a median overall survival of 9.2 months versus 13.4 months with the sorafenib. So majority of toxicities are manageable, and with a clear improvement of both OS and PFS, making the atezo and bevacizumab is the backbone of advanced hepatocellular carcinoma in the worldwide. So already this slide is explained, and the differences between the RW and RCT. And if you look at the safety and efficacy of A plus B in the unresectable hepatocellular carcinoma, this is the already Kerala study. And if you look at the methodology, it is a retrospective study, multicentric study conducted in the Amrita Institute and Aster Medicity, and which was conducted between the September 2022 May 2024. They are included the 104 104 patients with the unresectable HCC, and about 72% received the atezolizumab and bevacizumab combination as per standard doses, and single agent atezolizumab received 28% of patients. So importantly, and only 47% met IMBRAVE 150 inclusion criteria, making this is a it's a really real world cohort. Coming to the baseline characteristics, and if you look at the median age comes around 60 years, that is 67, and predominantly male patients, and most of the patients are belongs to child pug A category, and ECOG PS is 0 and 1. The most common etiological factors, that is viral hepatitis and alcohol related cirrhosis. These are the two major etiological factors, and the inclusion of child pug B and previously treated patients, which adds the generalizability of these findings in our Indian setting. So this was missing in the original IMBRAVE 150 trial. So if you look at the baseline characteristics of a number of hepatic lesions, nearly they are included the 48 48 number, and those are having those patients who are having a varices, and they are received the banding in 10 patients, and those previously received the systemic therapy, whether in the form of sorafenib or lenvatinib, that is 10 by out of 10 patients are received that, and treatment undergone, those were already mentioned, 75%, 75% are received the 72% are received the atezolizumab and bevacizumab, and single agent atezolizumab received 28% of patients. If you look at the best radiological response to the therapy, and the overall response rate was 33.8%, and the disease control rate was 63.2%, with 10% of patients achieving the complete response. So these are the impressive results in the real world setting, and which is correlating with the IMBRAVE 150, so which is demonstrating the similar efficacy, and which can be achieved outside a trial environment. Coming to the non-evaluable radiological responses, and the main reasons, and there are a few patients could not assess radiologically. Why? Because there are some reasons which those patients are due to early deterioration and loss of follow-up and logistic issues with the imaging during treatment. These are the some reasons which they are not assessed radiologically. This reflects the common challenges in the real world setting with the data collection. Coming to the overall survival, if you look at the median overall survival was about 15 months in the total cohort, and nearly 19.5 months for the childbirth A patients, and which is correlating with IMBRAVE 150. And this indicates that Indian patients derive comparable benefit with appropriate selection and monitoring. So these are the, if you look at the, those are irrespective of child PGA and LB grade, and age group wise, those patients who are receiving the prior local regional therapy, those who are not received any prior LRT, and this is comes around 19.4 months, and those are received the 1 to 2 times of local regional therapy, it comes around 22.8 months. Coming to the PFS, the median PFS is approximately 6.2 months across the both child pug A, it is 6.3, and the child pug B, it is comes around 6.2 months. So it is similar between the child pug A and B subgroup. So even with the moderate hepatic dysfunction, and the combination offers a meaningful disease control, and so that it is helpful in our regular practice setting. So majority of in our OPDs, most of the time, majority of our patients are belongs to B compared with A, and majority of what we are seeing is child pug B patients. So with this available data, and with this Kerala study, and it is very safe to use in child pug A even with moderate hepatic dysfunction. Coming to the safety and tolerability, in general, what we are regularly seeing is atezolizumab and bevacizumab. Definitely, with the combination, majority of patients are very well tolerated, and the most frequent adverse events are fatigue, hypertension, proteinuria, which we are monitoring regularly, and they are manageable with standard measures what we are taking, and there are very few discontinuations, and no unexpected safety signals is noted in the particular study. Coming to the conclusion, to summarize, atezolizumab and bevacizumab is very safe and effective and well-tolerated option, very good option for those who are unresectable HCC in real-world Indian patients, with an overall response rates of 33.8% and DCR of 63.2%, OS of nearly 15 months. And particularly, if you look at the child pug A, it is 19.5 months. PFS benefit is also seen in 6.2 months in the child pug A, and with the child pug B also it is similar, and there were 10% patients who received CR in the real world study also. And survival and response to therapy depending on the severity of liver disease, and those who are receiving the prior LRTs, the survival benefit is appear to be maintained regardless of whether patients who has received the prior local regional therapies. So the study found that combination of atezolizumab and bevacizumab is the safe and effective option. Those patients with the unresectable hepatocellular carcinoma, with particularly having a manageable toxicities. I think with this, I would like to stop here, and thank you again.
Thank you, sir. That was a wonderful session. For the next session, I would like to invite Dr. Bala Stalin Chaudhary. He's a senior consultant medical oncologist at MGH Vishakhapatnam. Welcome, sir.
Hope my slides are visible. I am audible.
Yes, sir.
Okay. Thank you. Thank you, AstraZeneca, for inviting me to deliver this. So over the next 10 to 15 minutes, we'll see how we have improved the overall survival and quality of life of patients of unresectable hepatocellular carcinoma. So this is the BCLC and ESMO guidelines for treating unresectable hepatocellular carcinoma. So we all know that any patient with a portal invasion or extrahepatic spread or is not suitable for either the locoregional therapies, any of the locoregional therapies. And for those patients who have at least an expected survival of more than 2 years, so these are the ESMO and BCCLC updated guidelines, where the first line consists of immunotherapy backbone. So previously it used to be TKI backbone. Now everything has moved to the immunotherapy to be used in the first line. So the two options available are atezolizumab plus bevacizumab, immunotherapy along with VEGF monoclonal antibody, or a dual IO, durvalumab or tremelimumab. If patient is not suitable to use them, or if the patient is not affordable for use them, we have other options like sorafenib and lenvatinib. So both the ESMO and BCCLC guidelines say the same. And post immunotherapy, so we have option of using various TKIs like regorafenib, cabozantinib, and ramucirumab. So these are the various phase 3 trials which happened in advanced HCC. So way back, right from the SHARP trial where sorafenib was compared with placebo and shown to have a 3 to 4 month overall survival benefit. The sorafenib has become the standard of care since 2007 and 2008, and it has been the only therapy which has been being used for almost a decade, more than a decade. After that, the REFLECT trial came, which is a non-inferiority study where lenvatinib was compared with sorafenib and shown to have better quality of life with almost similar survivals, and lenvatinib became the standard of care then. So right from 2020 to 25, so a lot of developments happened, especially with the advent of immunotherapy. So much improvements have been there in the survivals and outcomes of the unresectable hepatocellular carcinoma patients, and we now have a various armamentarium of drugs which we can offer to the unresectable hepatocellular carcinoma patients. Right from the combination, the first thing which has the longest follow-up and which has the longest data and has been being there since last 4 to 5 years is the combination of atezolizumab bevacizumab. After that, various other combinations came, the like dual IO with either nivolumab, ipilimumab, or durvalumab, tremelimumab, and TACE. Now, previously either TACE or TKI was used. Now TACE has been used with a variety of combinations. This is the landmark IMB 150 study where which showed the benefit of atezolizumab bevacizumab compared with sorafenib, then the standard of care, where patients with locally advanced or metastatic or unresectable hepatocellular carcinoma who have a more than one measurable lesions without any prior systemic therapy were randomized in a 2:1 fashion to receive either atezolizumab bevacizumab or sorafenib, and the patients were treated until the loss of clinical benefit or unacceptable toxicity with a primary endpoint of overall survival and progression-free survival. So these are the baseline characteristic, and this study did include 26 of the percent of the patients with esophageal varices if those were inactive or had been treated. So before using this combination of atezolizumab bevacizumab, it is mandatory to do an upper GI endoscopy to check where the varices, if there need some form of therapy with banding. So the banding need to be started, and we will start after at least some 10 to 14 days after the banding, we can start off the treatment itself. So these are the various baseline characteristics which were almost well balanced between the two groups. So almost 63% of the patients in ATBEV has an extrahepatic spread, and major vascular invasion was seen in almost 40% of the cases, and prior TACE was in the 40% of the cases, and prior RT in the 10%. And by and large, so baseline characteristics are well balanced between the two groups. And the patients who characterized as the highest risk and considering as a poor prognosis, that is a VP4 or a tumor more than 50% of the liver or bile duct invasion, constituted almost around 1/5 of the cases. So IMBRAVE 150 included 1/5 of high risk features, which may reflect the real world patient profile and provide evidence benefit to wide range of patient types. And these patients have poor prognosis, which are excluded from the other IO trials. And this is the updated analysis of OS and 1.5 year. So the overall survival was improved by 12%, 40 versus 52%, and the median overall survival was improved by approximately 6 months, that is 13 versus 19 months, with a hazard ratio of 0.66. And this is the updated PFS analysis. The PFS was different by approximately 2.6 months, and the 1 year PFS was different by 14%, 21 versus 35%. And atezolizumab bevacizumab also showed higher amount of response rates and complete remission rates versus sorafenib. If you see the complete remission rates, it was less than 1% in the sorafenib according to the RECIST 1.1, whereas it was 8% with the atezolizumab bevacizumab. Even the partial response also almost double, 11% versus 22% with the atezolizumab bevacizumab combination. This is the OS subgroup analysis. Majority of the subgroups benefited significantly with the combination of atezolizumab bevacizumab, except for the non-viral HCC patients. There was no much benefit, except for that atezolizumab bevacizumab was almost extremely superior compared to the sorafenib. And the post-hoc analysis of etiology and outcomes. So disease etiology and outcomes after atezolizumab bevacizumab. This is a post-hoc analysis of IMbrave 150 study. There was no significant difference in the proportion of patients who had a response across etiologies. If the patient had a response, then they will have an extremely better outcome. And no significantly different across multiple comparisons, and disease etiology should not be factored into consideration when using atezolizumab plus bevacizumab and likely other checkpoint inhibitor regimens for the treatment of HCC. Those who have a very good response, they tend to have a extremely good survival compared to the patients who doesn't have a response. And in IMbrave 150, efficacy of atezolizumab was observed across the etiologies. So the PFS and overall benefits of atezolizumab bevacizumab were observed across non-viral etiologies also. If you see in the non-viral population, HBV population and HCV population, the median progression-free survivals and the overall response rates are significantly better with the atezolizumab bevacizumab combination compared with the sorafenib. So no clear pattern of in non-viral and viral etiology. So the combination immunotherapy either in the COSMIC 310 trial or Himalaya trial. So no clear pattern across endpoints. Be cautious when interpreting these figures. So these are the sub-analysis and these are hypothesis generating only. Then these are not conclusive of anything. So coming to the safety and health related quality of life, if you see all grade adverse events, so atezolizumab bevacizumab, so a majority of the patients have some form of grade 4 adverse events, but grade 3, 4 are seen in only half of the patients, 57 versus 55, almost similar between the two groups. And the most frequently reported grade 3, 4 adverse events are the hypertension. We all know that bevacizumab causes it significantly, AST increase and proteinuria. So majority of the adverse events are because of the bevacizumab in the AT-BEV combination, and adverse events leading to treatment discontinuation are seen in only 16% of the patients in the AT-BEV, whereas 10% in the sorafenib. In sorafenib group, hypertension and HFS and diarrhea and decreased appetite are most common. So the time to deterioration of the quality of life was worse with sorafenib compared to the atezolizumab and bevacizumab. And the concept for treatment goal with unresectable HCC. So how we decide the therapy of choice, almost always in any metastatic or unresectable or advanced diseases, overall survival prolongation is the key. Apart from that, preservation of the quality of life, preservation of the liver function for the subsequent therapies, and manageable side effects and good direct anti-tumor effects are also extremely important. So to prioritize this, so prioritized requirement for the first line systemic treatment of thing. So we need a regimen, so which has a longer progression-free survival and overall survival, which can produce higher amount of responses with less amount of progressive disease. Along with patient, it should have a lesser number of side effects and deterioration of the quality of life. If you see across various trials, so the STRIDE regimen, atezolizumab and atezolizumab and the nivolumab, ipilimumab. So if you see by and large, so atezolizumab has a longer median overall survival of 19.2 versus sorafenib 13.4. In with the nivo EPM, so it is 23 versus 20, and in the STRIDE it is 16 versus 13. So if you see the Kaplan-Meier curve separates as early as 1 to 2 months, it produces better response rates compared to the dual IO inhibitor. So in the STRIDE regimen, the Kaplan-Meier curve separates right from 6 months onwards, and with the nivo EPM, it separates at about 12 months. If you see the atezolizumab, so it separates as early as 1 to 2 months itself, and at the end of 1.5 years, the magnitude of benefit is approximately 12%. So atezolizumab in combination with bevacizumab for the management of patients with hepatocellular carcinoma in the first line setting. So even the systemic literature review and meta-analysis, if you have seen, so the amount of hazard ratios were significantly better for the combination of comparison of atezolizumab bevacizumab versus sorafenib compared to other combinations. So this is the even patients with stable disease has a reasonable OS with this combination. So progressive disease patients are relatively much lower with atezolizumab compared to the newer IO trials, as we have seen that the responses are significantly there starting right from the first 2 months itself. So even the depth of the response, atezolizumab bevacizumab demonstrated a good depth of response compared to the sorafenib. If you see the tumor shrinkage population, it is almost 74% compared to the sorafenib, and the median follow-up duration was nearing 2 years, that is 20.2 months in the tumor shrinkage population, and it is 7.62 months in the non-tumor shrinkage population, which was quite significant. So even the duration of response is also significantly better. It is 14 versus 18 months, so 4 months difference in the duration of response with the combination. So 3 factors of tumor response for the long-term survival. So it produced a high response rates, very early response also as early as 1 to 2 months, and also deeper response rates and also the longer response rates. It satisfies all the criteria, and even VP4 versus non-EP4 efficacy and safety wise also. So it has shown to have a in the both subgroups, it has shown to have a good decent difference in the survivals compared to the survival. In the non-VP4, the survival was different. The median overall survival was different by 6 months, and the progression-free survival by approximately 2.4 months. And VP4 group, which is considered as one of the high-risk group, even in the high-risk group, so the survival was improved by approximately 2 to 2.5 months. And despite the treatment duration for patients with atebev was around 3 times longer than the sorafenib, similar incident of treatment-related adverse events were observed, and there was no much deterioration in the quality of life. The modest increase in variceal bleeding and grade 5 intestinal hemorrhage, which is seen in patients with VP4, receiving atezolizumab plus bevacizumab, was consistent with the disease pathology. Most events were not considered to be related to the study treatment by the investigators. And in patients with varices, atezolizumab bevacizumab demonstrated efficacy benefit over sorafenib, but all the patients need to be treated as per the local standard of care before starting with this regimen. So the majority of the bleeding events are unrelated to the varices, and epistaxis was the most common bleeding event with atezolizumab bevacizumab, 10.3%, and the majority of bleeding events were only grade 1 to 2. And if you see the esophageal varices or GA hemorrhage, they were quite less. So if you see the all grade, it was only 2.4%, and compared to the other bleeding episodes, the majority of the bleeding episodes were the epistaxis, which was seen in 10% of the population. And these are the practice guidelines by the American Association for the Study of Liver Diseases on the prevention, diagnosis, and treatment of hepatocellular carcinoma. They should undergo an EGT to assess for the high-risk stigmata for varicella, and the optimal treatment of large varices prior to atezolizumab plus bevacizumab initiation is known, and although recommends at least 1 session of banding. Patients with recent GI bleeding within 6 months and those with high risk for bleeding on endoscopy should have varices adequately treated prior to starting it, because they can increase the risk for higher amount of gastrointestinal hemorrhage. So the optimal time to wait between band ligation and initiation of atezolizumab plus bevacizumab to minimize risk from is unknown, although 2 weeks is likely reasonable given risk of post-banding ulcers. So these are the treatment goals by stage of hepatocellular carcinoma. So majority of the goals were prolonging OS by multiple lines of treatment while maintaining the liver reserve, and also to provide tumor shrinkage and necrosis and cure by combination of systemic therapy and the loco-regional therapies. So these are the various treatment goals to preserve the liver function, to preserve the patient quality of life, so that multiple later lines of treatment can be given to the patient. So thereby we can give good recent survival for the patient. So ultimately we can improve the overall survival, progression-free survival, and availability to receive the future treatments. So these are the various patient-reported outcomes. The time to deterioration of the quality of life is also significantly better with the atezolizumab compared with the sorafenib. So this is the changes in albumin, bilirubin grade analysis in a phase 3 study. So up to 30 cycles, patients treated with atezolizumab bevacizumab still maintained ALBA grade and continued to receive the treatment compared to the sorafenib. And these are the subsequent therapy rates. More than 70% of the patients are eligible for second line treatment because there was a good preservation of liver function, so that patients can be able to receive the second line therapies. That is the biggest problem in hepatocellular carcinoma, because we have seen with the sorafenib that majority of the patients, almost 70 to 80% of the patients, have a deterioration in the quality of life or in the deterioration of the liver function, which lead to not able to receive the later lines of the therapy. But this doesn't happen with the atezolizumab bevacizumab in the era. More than 70% of the patients were be able to receive the second line treatment. And it has also been shown, not only in the trial, it has also been shown in the real world data from the Korea and Japan, where almost 6% in patients with Korea and 82% in the Japan received the second line and subsequent therapy. And the real world data, the 5-year OS, the long-term outcomes in the Taiwan, which showed that. So if you see the 5-year overall survival rate is 20%, and 3-year overall survival is 31 points. So 1/3 of the patients are crossing the 3-year landmark. And if the patients are going to get a good response, so they tend to have a extremely good survival in those patients who got a response. So even the 6 months, the 60-month, that is 5-year overall survival rate is nearing 50%. That is almost half of the patients are crossing the 5-year landmark, those who are getting the response. So to conclude, IMbrave 150 suggests that AT plus Bev continued to demonstrate a consistent clinically meaningful treatment benefit versus sorafenib. The median overall survival was improved by 6 months, and the median PFS was improved by approximately 2.6 months, and the overall response rates and CR rates were significantly better. And the safety and affordable tolerability profile of atezolizumab plus bevacizumab remains consistent with the known safety profiles of each individual drug and the underlying disease. And majority of the times, it is the side effect profile is because of the bevacizumab, and atezolizumab is a quite well tolerated drug. Atezolizumab plus bevacizumab provides one of the longest survival seen in the frontline phase 3 study of IMbrave 150 in advanced HCC, despite including patients with high-risk baseline characteristics. As we have seen, 1/5 of the patients have a high-risk baseline characteristic, confirming this combination as a standard of care for previously untreated unresectable HCC. And the effectiveness and tolerability profile of AT-bev in real-world evidence also remains consistent with the clinical trial. Right from we had seen the Japan trial, we had seen the Indian data, we had also seen the Korean data, where the survivals were almost consistent even in the real world, not only in the trial setting. Thank you.
Thank you so much for this insightful session, sir. For the next session, I would like to invite Dr. Bhaskar Bowen. He's a consultant medical oncologist at MGH Vishakhapatnam. Welcome, sir.
Sir, Dr. Bhaskar, sir, can you please share the screen, or can I share, sir? Sir, your voice is not audible, sir.
No. Hello?
Yes, yes. Yes, sir,
Am
we
I
can hear
audible?
you, sir. Yes, sir.
Yeah, please share my slides.
Yes. Yes, sir, go ahead, sir.
Yeah. Thank you, Rosh team, and for giving this opportunity. So my topic is related to the role of Tecentriq, that is atezolizumab, in first-line patients with advanced non-small cell lung cancer, not eligible for the platinum-containing regimen. Next slide. Next slide. Irfan, next slide.
Yes, sir, just a minute, sir. Just a minute.
Yeah. Next slide. Can someone change the slide?
Yes, sir. Yes,
Yeah,
sir.
next
Now,
slide. Yeah. Okay, yeah. So we know that lung cancer is one of the predominant cancer in India, both in the world, and where in India it is one of the most common in the top 5 cancers after breast and cervix and lip and oral cavity. Lung cancer is the fourth most common cancer, which is leading to the death. And every year we know that 81,000 of lung cancer new cases are presented to the hospitals in India, with around 75,000 patients are having mortality. So, a majority of the non-small cell lung cancer patients are continuing to be diagnosed at an advanced stage. We all know either stage 3 or stage 4. Next slide. So, there is always an unmet need in the patients with the lung cancer in view of unsuitable to the platinum doublet chemotherapy. Many patients diagnosed with lung cancer are considered unsuitable for the platinum-based chemotherapy because of multiple things. So, nearly 40% of the patients diagnosed with lung cancer have ECOG PS score of 2 or more than 2, or substantial comorbidities are present, as well as they are excluded from many of the studies related to either immunotherapy and targeted therapy. So, and PS2 patients also have poorer survival when compared to the other PS0 to 1, regardless of the treatment design. So, and many patients at average age of more than 70 years are reported to the hospital with the advanced stage for lung cancer patients. Based on these factors and comorbidities and contraindications have happened because of their frail, less weight, and multiple factors are considered for the going for the doublet chemotherapy. So, because of these issues, many patients are excluded from the immunotherapy. Next slide. So, as I mentioned, initially we do the initial biopsy and IHC and PD-L1 expression, all these things. After that, once we plan for chemotherapy, the factors mainly decides the further therapy in these patients is that one is comorbidities like cardiac, renal functions, or age of the patients more than 70 years of age. Usually, we don't consider for the doublet chemotherapy, and social factors are also considered. Next slide. So based on these kind of things, one trial is the Moon versus trial, where it studied the various kind of factors involved with the platinum ineligibility. So in that it was mentioned that old age, comorbidities, poor PS, family factors, all these were considered as one of some of the important factors to consider platinum ineligibility or platinum doublet chemotherapy. Next slide. So in this observation study, it was found that many patients, almost 88% of the patients, combination of these factors like heart diseases, hypertension, chronic renal failure, cerebral disease, and CVA, diabetes, all these factors were part of this ineligibility thing in the trial conducted, where the age factor is one of the most important factors. More than 76% of the patients have age-related factors, and comorbidities have 72% of the patients comorbid-related issues. And ECOG PS2 is considered in 55% of the factors, and social factors are almost 10% of the cases. Next slide. So we know that there are other alternatives also for the patients who are unsuitable for the platinum-based chemotherapy, like gemcitabine, vinorelbine, docetaxel, pemetrexed. But over all these trials, docetaxel is the only trial where it was conducted in a phase 3 manner. When you see based on this ineligible criteria to the platinum, the median overall survival is ranges from the around 4 months to the 9 months, depending on the regimen used. But the phase 3 trial of docetaxel showed around 5.1 months in median overall survival. Next slide. So evidence from the single agent of immunotherapy in non-small cell lung cancer, particularly failed patients, has been very minimal or scarce. So there are no randomized phase 3 trials investigating first-line pembrolizumab in poor PS status patients or platinum-eligible patients. So one of the trials related to the pembrolizumab, that is PEPS-2 trial, which was conducted as a phase 2 trial. So it is a single-arm phase 2 trial regardless of the PD-L1 expression conducted, where it enrolled the 60 patients, of which 24 patients were first-line received patients. In here, it showed that median overall survival was 7.9 months, the first-line setting, with median PFS of 4.3 months. In the same way, nivolumab, ipilimumab was also tested in a phase 3 trial, but the trial was stopped early because of the high mortality rate, where the median overall survival was considered as 2.9 months. Durvalumab was studied in phase 2 trial, where the mortality rate in this group of patients was also very high because of that study was stopped. Next. So based on these trials and lack of data related to the immunotherapy in these elderly people are unsuitable for the platinum therapy patients, this trial, Ipsos trial was studied. So it is a phase 3 global multicentric open label randomized study where Asian patients, including Indian patients, were included into the trial. Itolizumab was a single agent chemotherapy in patients who were considered unsuitable for first line platinum tablet chemotherapy were considered in this patient. Next slide. So this is the based on the results of the phase 3 study of the first line itolizumab, as I mentioned, versus single agent chemotherapy in patients with non-small cell lung cancer not eligible for a platinum containing regimen. Next slide. So the pivotal clinical trial showed that first-line treatment with non-small cell lung cancer with immunotherapy with or without chemotherapy improved overall survival versus platinum doublet chemotherapy. So the guidance recommend that single-agent immunotherapy options for the patients with very high PD-L1 expression. However, these studies not recommend. Treatment recommendations are limited in patients, particularly with the PS elderly patient gains. In real-world settings, more than 40% of the patients with non-small cell lung cancer poor performance status is seen in 40% of the patients and are mainly elderly with multiple comorbidities and poor tolerance to the treatment. And given the relatively poor prognosis and limited treatment options, as so the poor prognosis in these patients, majority of these patients, we know that they were excluded from the clinical trials and So Ipsos study is the first phase 3 global multicenter open label randomized controlled study examining the efficacy, safety, and patient-reported outcomes with letrozole versus single-agent chemotherapy in patients who were considered unsuitable for first-line platinum doublet-based chemotherapy. Next slide. If you see the trial schema, the trial included all the patients who are stage 3 or stage 4, stage 3B to stage 4 patients of non-small cell lung cancer, where squamous and non-squamous histology both were included, where the platinum eligibility either because of the criteria is either PS2 or 3, if PS0 or 1 permitted, if age is more than 70 years of age with substantial comorbidities or other contraindications to the platinum-based chemotherapy. Patients who are considered having EGFR and ALK mutations were completely excluded. Patients with treated with asymptomatic brain mets are also permitted in the study. The stratification factors for the trial are histology, that is squamous versus non-squamous, PD-L1 expression. Based on the initially it was enrolled based on SP142 IHC, but later the study outcomes were studied based on the SP263. And brain mets present or absent based on that. The primary endpoint in this study is the overall survival, where the secondary endpoint of the overall survival at 1 year, 1.5 years, and 2 years, PFS, objective response rate, duration of response, and worst period positive subgroup. Other patient-related outcomes and safety outcomes are also studied. So in this trial, the randomization happened in the 2:1 ratio, where the investigation arm included all the eligible patients until disease progression. In the other arm, the placebo arm or the control arm has vinorelbine or gemcitabine. Next slide. If you see the baseline characteristics of these patients, the median age is around less than 70, is considered almost 25% of the patients, where 70 to 79 years of age is almost 40% of the patients. You can see PS2 or 3 are majority of the patients, PS2 is 75%, and Asians are 25% in the group. Squamous histology is almost 40% in the group, and smoking history was previous smoking history is almost 70% of the group present, and brain mets is present in 20% of the patients. And the PD-L1 group was also assessed in all the groups. Next slide. So the main primary objective, that is overall survival, the primary endpoint if you study, when compared with the chemotherapy, atezolizumab showed the median OS of 10.3 months with 9.2 months in the chemo, with the hazard ratio of 0.78 with the significant p-value. Next, the median follow-up was 41 months. And you can see that at 1 year, that is 12 months, it is the difference is low, but at the end of 2 years, it's almost double, 12 versus 24%, the median OS. Next slide. If you see the forest plot for the overall survival, as per the factors of age, gender, race, and PS, All these factors showed improvement towards the atezolizumab, whether histology-wise, non-squamous or squamous, and the patients having brain mets or without brain metastasis, and irrespective of the PD-L1 expression level also, it showed more or less the similar outcomes in the atezolizumab group when compared to the chemotherapy. Next slide. So the other endpoints like median progression-free survival, where it showed that median PFS in the atezolizumab arm were 4.2 months, whereas in the chemo group it is 4 months. Even the marginally it shows less, but the hazard ratio is 0.87, and the outcomes are continuing to show benefit beyond 24 months also. Next slide. So the second endpoints of overall response rates and duration of response, we can see that the overall response rate was 16.9% versus 7.9 months, whereas the CR rate is 1.3% in atezolizumab, and PR rate partial response was 15 versus 7.1 months, doubling of the partial response, and stable disease was also relatively high. And the disease control rate is 57% and 56% in both the groups. Next slide. So the patient-related outcomes like role function, social function, cognitive functions, all these factors showed improvement for the atezolizumab remained stable when compared to the chemotherapy, where the chemotherapy showed little bit deterioration in these functions. Next slide. So the other health-related quality index like cough, peripheral neuropathy, insomnia, chest pain, alopecia, all these things, appetite, all the factors also showed improvement towards the atezolizumab, except the insomnia, where chemotherapy showed better insomnia pattern. That is the only thing. Otherwise, in the remaining all the health-related quality of life parameters, atezolizumab showed the benefit. Next slide. So the chest pain, the median time to confirmed deterioration for the chest pain also relatively the atezolizumab arm showed better response in these patients next compared to the chemotherapy. Next slide. So when it comes to the safety profile, the median treatment duration in the months is 3.5 months for the atezolizumab, whereas it's 2.3 months in the gemcitabine or other chemotherapy arm, and median number of cycles initiated was the 6 versus 4, and the treatment-related adverse events were around 57 versus 80% in the chemotherapy arm, and grade 3, grade 4 adverse events were 16 versus 38%, and treatment-related serious adverse events were 11 versus 15. So relatively, the chemotherapy arm showed more toxicity compared to the immunotherapy arm, and adverse events leading to the discontinuation of study drug was 13%, and both the groups had shown 13%, and adverse events leading to modifications or interruptions of study drug 32 versus 48%. Next slide. So adverse events of the special interest like immunotherapy side effects, if you see, the immune-related rash is 15 versus 7%, and immune-related hepatitis and is seen almost 10 versus 6%, and immune-related hypothyroidism is 9 versus 0.7, and hypothyroidism is 2 versus 2. So all these factors showed that manageable toxicity with the immunotherapy with reasonably high when compared to the chemotherapy. Next slide. So Ipsos study empowering the ineligible patients, where the 76% of the Ipsos study population are PS2. So treatment option for PCOG2 patients normally platinum ineligible they will be considered, or otherwise they will be considered treatment ineligible. Such kind of patients will be given for this kind of therapy, where the outcomes are far better than chemotherapy. And the treatment option for patients with reduced renal function because of the elderly age or other comorbid factors, the creatinine case is also very high in this group. So for these patients also, this study helped, and 73% of the patients with Ipsos study is age more than 70 years, and 31% of the more than 80 years. So the treatment option for this elderly group is also, we can consider immunotherapy as one of the options with its very favorable safety profile. And number of ongoing comorbids for Ipsos study patients is that is around 6 in the immunotherapy group, whereas 5 in the chemotherapy group. Next slide. So Ipsos guideline recommendation suggests that NCCN guidelines, if regimen is included in NCCN guidelines, we all know that in the PS3 patients, regardless of the PD-L1 expression, the ESMO guidelines, the Ipsos included in the recommendation section for the ESMO also for the recent update. Atezolizumab monotherapy can be considered for patients ineligible for the platform-based chemotherapy due to PS2 or more than 2 or age more than 70 with comorbids, regardless of the PD-L1 status. Next slide. The conclusion of the study is First-line atezolizumab significantly improved overall survival over third-generation single-agent chemotherapy with a hazard ratio of 0.78 in patients with non-small cell lung cancer who are deemed ineligible for the platinum doublet chemotherapy. And this benefit consistent across all the subgroups, that is whether patient's age, histology, PD-L1 expression levels, PS score. And the two-year OS rate, we studied that it is almost double, that is 12 versus 24%. And the overall response rate was higher with atezolizumab with more durable response, that is 14 versus 7.8 months. Atezolizumab was associated with maintenance of health-related quality of life functioning domains, significant improvement time to deterioration of the chest pain also when compared to chemotherapy, except for the insomnia part. And treatment-related grade 3, grade 4 adverse events, serious adverse events, and other events occurred in smaller proportion of the patients receiving atezolizumab when compared to the chemotherapy. And the adverse events, special interest, also manageable number, and no new or unexpected safety concerns were identified with the atezolizumab. And Ipsos is the study, first randomized phase 3 study to show that first-line treatment with atezolizumab improves overall survival in this poor prognosis non-small cell lung cancer patients with no EGFR alterations, with no new CPS signals identified, while maintaining the quality of life. Next slide. Thank you.
Thank you, sir. After this amazing session, we move on to our next speaker, Dr. Sanat K. He's a senior consultant, medical oncologist at Basvatakaram Indo-American Hospital, Hyderabad. Welcome, sir.
Thank you. I think I am audible and my slides are visible.
Yes, sir.
Okay. So first of all, I would like to thank Roche team for providing me this opportunity. Today we will discuss about the 6-year survival in patients with extensive stage small cell lung cancer treated with atezolizumab in IM Power 133 and IMbrella extension study to the IM Power 133. So these are my disclaimers. And if you see rationale for IM Power 133, so we all know small cell lung cancer is the most chemosensitive, radiosensitive cancer. And we can say rare lung cancer. So because it is around, we can say 10 to 15% of all lung cancers. But though it is chemosensitive, the paradox is, so relapse rates are around 90 to 100%. So every small cell lung cancer patient, definitely around 90%, they will have relapse. So that's why the overall 5-year overall survival rate, though it is one of the most chemosensitive cancer, it is only 2%. And median overall survival was 10 months. Unlike non-small cell lung cancer, there is very less mutation load, very less target drugs for the small cell lung cancer. So we have n number of drugs for the non-small cell lung cancer, but till now only chemotherapy, carbo, itapo, and topotecan, irinotecan. These were the only drugs for small cell lung cancer, and there were no target drugs except for the immunotherapy. 2 immunotherapies are approved at present. They are atezolizumab and durvalumab. So if you see the 5 years overall survival rate is only 2% with chemotherapy alone in small cell extensive stage small cell lung cancer. So about the IM Power 133, so here they have tested atezolizumab plus chemotherapy versus standard of care, we can say placebo chemotherapy. Patients were around 400 and sample size was 403, ECOG performance score 0 or 1, chemo naive, extensive stage small cell lung cancer, and patients treated with treated asymptomatic brain mets were eligible. So and the stratification was male versus female, ACOG performance score 0 versus 1, and brain metastasis yes versus no. So induction, they will give, we have to give both carbo, itapo, atezo versus placebo. Then along with that, maintenance atezolizumab until progressive disease or loss of clinical benefit. And PCA is as per local standard of care. It depends upon the institute to institute. And the primary endpoints for overall survival and investigator assist PFS, whereas key secondary endpoints for objective response rate, duration of response, safety. And here the chemo backbone was carboplatin and etoposide.
Sir, you are in mute, sir. Voice is not audible.
Still not audible, sir.
No, sir. Still, your not voice is not audible, sir. Suddenly drops, sir, your voice. Screen is visible, sir. No, sir. Not yet. Sir, speak, sir. No, I think it's audible now. No, sir. No.
Still not audible, sir.
You'll, otherwise, yeah. I think Sari is joining back. No, sir. On the keyboard, yeah, it might have unmuted, sir. Keyboard. Just see, sir, any key.
Hello.
Yes, now audible, sir.
ఏంటి హలో
హలో నేను ఆనంద్
ఉన్నాను మీరు వస్తారా ఇప్పుడు?
Dr. Bhaskar, sir.
ఎంతసేపు వస్తారు మీ ఫ్రెండ్ మా పండుగ వచ్చిన తర్వాత నాకు కాల్
Sir, your voice is not audible, sir.
Can you share the slides? Can you share the slides? Hello?
Avni, do you have slides with you?
Sir, I don't have Dr. Sanat's slide. If you can share, present.
Just check with Dinesh once, please.
Sir, I just called him. He's sharing the PPT with me. Can we just wait for 2 more minutes?
Yes, I am ready. So from the beginning, it was not audible, or it was in the in between.
No, sir. In the beginning, it was audible.
Okay,
The later
sorry,
part,
sorry.
okay. I think Mr. Dinesh is also not able to share. ये जो मेल आईडी सर इनबॉक्स में है आप इस पे एक बार मेल कर देंगे तो दैट वुड बी कन्वीनियंट.
Sure. Definitely.
Okay.
Done. It was done. Shared. How many have shared it? Can you open?
Okay, sir. I'll just check. Just a second. I hope the screen is visible.
No, screen is not visible. Now it is visible. Can you
Sure.
go ahead? Go ahead. So next slide, please.
Just a second, sir.
Okay, sure. Next slide. Next slide. So correct. So there is overall survival benefit, though delta is less, but definitely there is overall survival benefit. 30% risk reduction was there. And in the PFS also, there is around, we can say, 23% risk reduction is there. Absolute numbers are low, but there is a difference. And if you see at 6 months interval and at 12 months interval, around 8% difference in the 6 months interval and uh, around 8 to 9% difference in the 12 months PFS. Next slide, please. And if you see updated safety profile, there are no new side effects or extra side effects with adding atezolizumab. It is equivalent to placebo or chemotherapy. So there are no newer side effects. We rarely see any grade 3, grade 4 side effects with atezolizumab. Next slide, please. So summary, atezolizumab is one of the immunotherapy which is approved in extensive stage small cell lung cancer, and it has the survival benefit and progression free survival, and the overall survival benefit, if you see at each time point, it is at 1 year or around 18 months there is benefit, and even in PFS there is benefit. This is the only one of the immunotherapy which has the longest data, we can say, that is 6 years, that we will see in the further slides. And there are no new safety signals approved, we have seen. Next slide, please. So if you see the 6 years data, this is the only trial which has shown 6 year data. This is the continuation of IM Power 133, that is IMbrella, and extension study results. Next slide, please. So it is an extension study. It's a non-randomized, multi-center extension, long-term observational study. So here in this, only the experimental arm of the IM Power 133 were included, not the placebo arm. So they have included from December 2019 to July 2020. And the number of sample size or number of patients for 18. So who were on maintenance, they have taken and they have followed. Next slide, please. So if you see IM Power 133 versus IMbrella, which is an extension study, here the number of patients for in the experimental arm, they were 201 sample size. Here it is 18, and median age overall things were matched. If you see, but the ECOG performance score was zero, even in we can say 66%, and brain mets were there in 11%, and liver mets patients were there around 11%. Next slide, please. This is same. Next slide. 5 years or 6 years overall survival data. If you see the 5 years overall survival data, the IMbrella it has shown around, initially it was only 2%. 2% 5 years overall survival in the small cell lung cancer. Now it is 12%. So 10% extra is there with adding atezolizumab. And if you see 6 years data, it is around 11%. So 10% in a worst prognostic cancer is not a small number. And patients who respond on immunotherapy, definitely they continue to respond, and without any additional or newer serious side effects. Next slide, please. So these were continued patients who were from the IM Power 133. The number of patients were 18. Mostly those who responded well, those who who are on maintenance immunotherapy, they were included. Next slide, please. Safety outcomes, even maintenance, there are no newer safety signals or safety side effects. They are equivalent to the IM Power 133. We won't see any serious side effects in a long-term follow-up. Most of the immunotherapy side effects will be in first 6 months, usually. Next slide, please. So if we compare across trials, one slide blank. So if we compare across all the trials, so 2 immunotherapies are approved, that is durvalumab and atezolizumab at present. IM Power 133 and Umbrella is the longest follow-up, we can say, only 3 years. Whereas Keynote 604, the follow-up is also 3 years. 6 years this is the only trial which has 6 years follow-up, and at 6 years, around we can say 12% of the patients were alive. And it is a tolerable regime, though the magnitude of benefit is low even with these immunotherapies, but there is no other choice, or there is unmet need in small cell lung cancer. So newer drugs should even now. Thank you. Great. Amni, you can close. It has been completed.
Okay.
Thank you.
Thank you so much, sir. So for the next session, we have Dr. Anila. She's a senior consultant medical oncologist at AOI Hospital, Vijayawada. Welcome, ma'am.
Hello, good evening, everyone. Can I do the slides?
So excuse me, would it be possible to finish my lecture first? I mean, if you guys are okay with it. Team there?
I think if Dr. Anila is okay with it, we can do
if
that.
that's okay with you. Actually, unfortunately, some scheduling issues, and I actually have to go to another meeting. I hope it's okay with you if I do, because I was told that this would be at 8:30, but there's some confusion going on. Would it be okay if I present first?
That's fine.
No problem. Okay, thank you so much. And I really apologize for this late entry and just trying to present fast. I'm sorry for this. So I have been asked to speak on choosing wisely on HCC. And what I was thinking is we would present all the overview of the immunotherapy data that we have and try to make some sense out of this immunotherapy data. Because right now, we have quite a few of the combinations which are present. And these combinations for advanced inoperable HCC can lead to some confusion. Now, remember, all of these trials that we have essentially used immunotherapy with one of these. You either add an anti-VEGF, that is bevacizumab, or you can add an anti-CTLA-4, or you can add a TKI. The TKI alone. Remember, this TKI could be sorafenib, or it could be lenvatinib in some studies. But essentially, this is how the trials have been designed. Now, these are more or less all the trials, and I have included even the trials from the IM Brave. This is the updated efficacy. We have the 4-year survival from the Himalaya. We have the Checkmate 90W, which is Nivo EP. And then I have kept this study of LEAP 002 of Lenva Pembro, though it's a negative trial. And since we have these drugs, you do have a phase phase 3 randomized trial of Tislaley and a phase 3 trial of toripalimab. Right? These are the general trials, and all of them, like I said, have used immuno with something versus sorafenib, or immuno versus sorafenib, or immuno plus chemo plus TKI versus another TKI, that is lenvatinib. So that's how the designs are made. Let's go one by one through the trials. Now, I am not putting LEAP-002 because it is a negative trial, but I will touch upon it later. Now, interestingly to note that IMbrave 150 is a multiple ethnicity trial. It's a worldwide trial with VP4 included. Now, in practice, we see a lot of VP4. In practice, people don't generally comment upon VP1, VP2, VP3 separately, but any main portal vein, that is VP4, which is in general a bad prognostic feature, was included only in the IMbrave. So this is important to note. So in clinical practice, when you get somebody with a VP4, remember it was never included in the trials of Himalaya, Checkmate, Hepatorch, or Rational. So this is one of the things that you could possibly decide on which treatment to use. Again, the ethnicity matters. The reason being that the Hepatorch, which is actually a toripalimab study, was done exclusively in China, and it used 91% of patients who were HBV, which is what we see in China. The other trials, including IMbrave, have a much more equitable distribution. And remember, the percentage of non-viral is around 30 to 40% in the other studies. But in the two studies, which are primarily Chinese, these are lower in number. Why does this matter? Because in India, around 50% or so of HCC is non-viral. We don't have the viral in these numbers that you see, especially in China. Again, all the first 4 trials are phase 3 randomized control trials looking at superiority. The Rational, which is Tislaley, is a non-inferiority study. So again, this is something that we need to remember. Now, this non-inferiority is also an important point to remember. So let's come to the comparisons. Now, this chart, if you see, look at the numbers. Starting from the, I would put it as the Western data probably. Atezobev has 500 patients. Durva-Tremi has 782. Nivo-IP has 668. Tori has only 326 patients. Number of patients are less. Tislaley has a decent number. Again, look at the endpoints. Now, the primary endpoint for Atezobev, which was probably the first trial started, is OS and PFS. Durva-Tremi had only OS, Nivo-IP had only OS. Now, again, this kind of tells you when you're using a PDL1 inhibitor with a CTLA, because essentially that's what both of these are. Both kept OS as their endpoint. And when you look at the results, you kind of understand why. Look at these PFS. Now, the PFS for Durva-Tremi is 3.78 months versus 4.07 with no difference. The Tori-Bev and the Atezobev have a OS PFS advantage, both in the range of around 2 to 2.5 months. Look at Tislaley. Now, remember, Tislaley is a non-inferiority study, but look at the PFS. It's 2.1 months. Essentially, what that tells you is half your patients are going to be progressing within 2 months. Essentially, in the first time you're doing a scan, half of them are going to progress. So, Tislaley PFS of 2.1 is something we need to keep in mind like anything, because 2 months PFS. So then come to the other drugs. Now, here we have a very long period of PFS in Nivo-IP, which, people have been struggling to understand why. Remember, it could be because you used a slightly better population, no VP4, no MVI, and no large volume involvement. Therefore, look at the other side. Only Lenva arm, which was in 85% of patients, had a 9.2 month. So, in terms of, in general, when you compare, this PFS is a bit of an outlier, which is what all of us realize. Come to the ORR. Now, this is something interesting. Now, ORR cannot be completely removed from the progression rate and other things. The ORR is 36% for Nivo-IP with a progression rate of 19% as well. So again, Not that you are getting a ORR for sure, you are also getting a bit of a issue with the progression rate here. So let's come now to the OS. And here again, numerical values aside, look at the atezo-bev difference. And always we say, look at the hazard ratio. It's 0.66 here. The durva-tremi does have an OS. Remember, there's no PFS, but there is an OS which is around 3 months with a positive hazard ratio. Now, this is important in terms of fairness when you look at, because durva-tremi has 4 years survival data, which was not there with so far the atezo-bev. For reasons, because of technical reasons. The trial was supposed to be closed, therefore they did not follow up for OS. So you're not going to get a 4 and 5 years survival here, but then probably the delta is all we can compare. Look at the Nivo EP. Now, headline numbers, 23 versus 20 looks nice, but hazard is only 0.79. And most importantly, remember N1I3. It is EP3 versus Nivo 1. So look at this part where you have the grade 3-4 AEs. With Lenva, it was 32%, which is, well, not very easy to understand because we have taken the thing, and in every other trial where sorafenib has used, it is around 50% side effects. Whereas here it's only 32. Slightly difficult to believe. But then Nivo 1 EP3 is not easy drug to use as well. Next, looking at the Tori-Bev data, again, you have high amount of grade 3, grade 4 OS. Look at the Tislely data. Remember, this was a non-inferiority trial, so it did meet its endpoint. So technically, it's a positive study with a 1.5 month overall survival. But this benefit is hazard ratio of 0.85. It's a non-inferiority trial. There was no superiority seen in the study. And with 49% progressive disease, I think Tislely at least is kind of out of my equation. For Tori-Bev, PVTT was included in some, but still kind of having reasonable number of subsequent treatment as well. The durva-tremi arm, the durva monotherapy arm, again showed a progressive disease of 39%. So again, let's look at the numbers in slightly more detail. This is the updated PFS for IMBRAVE, which is what I told you, 0.65, better PFS. Updated OS again is 0.66, which is kind of the best hazard ratio that you are having across the places. The biggest advantage of STRIDE protocol, the durva-tremi, is this, that you have a 5-year updated OS. But look at this. The first 6 to 8 months, virtually kissing each other. After that, you see a separation which possibly lasts. Therefore, if you're looking at the headline of a bigger number and probably slightly bigger number of selected patients doing longer, durva-tremi may give you that. But when you look at the general tendency of overall survival from the beginning, the difference is more pronounced with the atezo-bev. So that's what we need to remember. So how do you make sense of all this data? One thing, remember, this is from a paper by Dr. Kudo, that whenever trials have used lenvatinib as the comparator arm, they tend to do better. Whereas whenever the standard of care has been the sorafenib, arm does worse. That probably explains why the LEAP failed, because LEAP was looking at lenvatinib plus lenvatinib plus pembro versus lenva. Similarly, your checkmate 90W also did not do so well because your lenva was 85%. So that makes a difference. So your trial selection, trial design matters. Again, when you're looking at the comparator arms, if you look at the Nivo, which is from checkmate, the durva-tremi or the Nivo AP, almost all of these studies have to beginning 1 year a less PFS and a less OS, whereas the len-pem and the atezo-bev. So essentially, IO plus a TKI does better than an IO plus IO to begin with. Over 3-4 years, they kind of merge together, so you cannot tell which is better, which is not. But at least for the first 1 to 2 years, the immuno plus a anti-VEGF agent will do better. That's the takeaway from this. IO tends to have a longer survival, but not in everybody, in a selected subgroup of patients. which is where this whole business of ORR comes in, which is where the progressive disease comes in. Remember, the progressive disease is around 20% in the IM50, in the IM Brave 150. Now, the other studies, which includes LEAP-2, Checkmate, and Himalaya, the progressive disease is higher. So 39% progressive disease in Durva-Tremi, 20% in the Nivo-EP. We are having more progressive disease, lesser number of people surviving for longer. How do you identify those patients? That's the key, which we really don't know. Again, coming back to IM Brave, another issue which we need to see is that it seems to work in all subsets with some hesitation over the non-viral. But again, this was a subset analysis, not planned. And later on, when they started looking at it, the systemic steroid usage was not as much as in the Atezobev as in the other arms, and the TRA discontinuation was also slightly lesser. So putting all this data for me, till now in this Game of Thrones, Atezobev probably still remains at the top for reasons of its PFS, its OS, and we have been using it, it's convenient. Only worry we have is with the variceal bleeding, and obviously if you're a bit careful of that, that can be taken care of. So you need to avoid, possibly the only contraindication is active variceal bleed. Otherwise, Atezobev seems to have a better responses. I'm not ruling out Nivo-EP and Durva-Tremi. In selected patients, it's probably good. Who are these selected patients? Good performance status, A5 or 6. Anything with B7 and above, absolutely contraindicated. The progression disease, the hepatic dysfunction is much worse with the dual IOs as compared to an IO VEGF. So that is a very, very important take-home message that if you have a B7 and doubtful PS, don't go for dual IO. Go for, if at all you want to give an IO and bevacizumab. Tori-Bev, it's cheaper, but beyond that does not really have great things to recommend as per trials. Tislely is approved, but it's a non-inferiority with a PFS of 2 months. I really don't want to use it. That's the way I would look at it. So my summary, if you look at it, Atezobev has the best hazard rate with well tolerated. OS may be slightly numerically lower. Non-viral, honestly, I think that discussion is over, but otherwise it's best used where Bev is, it's only not used where Bev is contraindicated. Because Atezo monotherapy, we don't think will work. What is the benefit of Durva-Tremi? OS benefit, no PFS benefit. Toxicity is intermediate, but high progressive disease. Nivo-EP has long OS and PFS and ORR, but highest discontinuation, highest TRA, and highest steroid use. So any patient who is likely to get a dysfunction in the liver, Nivo-EP, no. Any patient who is slightly on the borderline, dual IOs, probably no. Can we use Durva monotherapy? Yes, probably in those patients who are elderly with a PS2, where still OS is not maintained. Remember that. Tori-Bev, frankly, besides the cost issues, there's really nothing much to recommend it. It does have PFS and OS. It is well working in HBV. Beyond that, we don't know whether it will work in other places. So these are my thoughts. I am speaking a Roche meeting, but then this is how we generally look at patients as well when we need to decide. Remember, BCLC, BC, non-VP4, CPS8. This nice group, which is probably around 30% of your patients or 40%, will be amenable for all of this, where you can decide based on your performance status, based on your disease and other things. If it is VP4 with a large volume, probably Atezobev only, because that's the only thing that has been used in trials. Can we add SBRT tear? Can we use others? Well, plus minus as per case basis. CPS7, PS2. Remember, best supportive care is not bad. Guarded IO. Don't use IO indiscriminately. They can go really bad. CPS BC with BCLC D or a PS34, best supportive care is the only option. Enthusiastically using immuno does not help in such cases. So that's my summary. And thank you so much. And I again apologize for gate crashing the meeting for saying, and I'd be happy to discuss or take any questions from anybody.
Thank you so much, sir. That was a very wonderful session. So now, as we move to the final talk of the evening, it's my pleasure to invite our last speaker, Dr. Anila.
Hi, can you see my screen?
Yes, ma'am.
So, good evening, everyone. I'm Dr. Anila Patibandla. I'm working as a consultant clinical oncologist at American Oncology Institute, Vijayawada. So, the topic I've been given today is discuss the results of IM Power 150. This trial was looking at atezolizumab plus chemotherapy plus bevacizumab in first-line non-squamous metastatic non-small cell lung cancer. Thank you, Roche team, for giving me this opportunity. So in IM Power 150, it was a phase 3 study. First line atezolizumab plus chemotherapy plus bevacizumab in non-squamous non-small cell. So the clinical questions they were looking at were adding atezolizumab to bevacizumab plus carboplatin paclitaxel, would it add any clinical benefit? And is there any improved benefit if bevacizumab was replaced by atezolizumab? So patient selection was stage 4 non-squamous non-small cell lung carcinoma, chemotherapy naive, and stratification factors were whether it's male or female, PD-L1 expression, IHC expression, and they've included patients with liver metastasis. So total intake was around 102 patients. They had 3 arms, A, B, C. So in arm A, it was atezolizumab plus carboplatin paclitaxel, going on to maintenance of atezolizumab until progression of disease progression or loss of clinical benefit. And arm B was atezolizumab, carboplatin paclitaxel, and bevacizumab, going on to maintenance of atezolizumab and bevacizumab. Arm C was carboplatin paclitaxel and bevacizumab, going on to maintenance of bevacizumab until disease progression. So the primary endpoints were investigator-assessed progression-free survival in intention to treat wild type group. What they mean by ITT-WT was patients with no EGFR mutation or ALK mutation, and TEF high wild type, where they included a subgroup which had high levels of expression of certain genes like PD-L1, CXCL9, and interferon R mRNA, which indicate more active T-cell immune response. So, and overall survival, other endpoint was overall survival in ITT wild type group. So, atezolizumab anti-cancer immunity is enhanced through bevacizumab. So bevacizumab enables efficient priming and activation of T-cell response and normalizes the tumor vasculature and enables reprogramming of the tumor microenvironment. So thus atezolizumab's ability to restore anti-cancer immunity through T-cell mediated cancer cell killing is enhanced by bevacizumab. So looking at the baseline characteristics, they have well-balanced between A, B, C, and arms. So males were around pretty much the same number and percentage across the 3 arms. ECOG perform status was the number of patients who had perform status 0 were balanced as well. And in terms of current smoker or previous smoker or non-smoker, these characteristics were balanced as well in the 3 arms. And similarly with the liver metastasis and EGFR mutation positive, ALK positive, KRAS positive or tested, and TEF gene segregation expression and PDL expression, they have balanced all these characters across the 3 arms. So 14% of patients had liver metastasis at baseline, and 10% of patients had EGFR mutations, and these patients were balanced across the 3 arms. And PDL1 positive and negative patients were split approximately the same across the arms. So if you look at arm B and C, so arm B is atezolizumab, bevacizumab plus carboplatin paclitaxel, whereas arm C is bevacizumab plus carboplatin. So there was clear overall survival benefit with arm B. If you look at arm C, the median overall survival was 14.7 months. And for arm B, it was 19.5, a difference of 4.5 months. And overall survival at 12, 18, and 24 months, arm B was doing well compared to arm C. Hazard ratio was 0.8. So looking at objective response rate and duration of response in intention to treat population. So high proportion of patients responded to in arm B, where eculizumab was added to bevacizumab plus chemo. So ORR rates were around 56% in arm B compared to 41% in arm C. So the response was across the PDL1 group, more so in the PDL1 high, but the benefit was there in PDL1 low and PDL1 negative as well. So if you look at arm B and C in PDL1 high, so arm B, the objective response rates were around 69%, whereas arm C, it was 49%. And duration of response, arm B was 11.5 months, whereas arm C was median duration of response. Arm B was 11.5 months, so arm C was 6 months. So that's what I mentioned. Our overall survival benefit was observed across all PDL1 subgroups in intention to treat wild type population subgroup. So PDL1 high patients derived the most benefit. So PDL1 positive TC123 or PDL1 negative TC0. Comparatively, the PDL1 positive ones did better. So where the median overall survival was 16 months in arm C, whereas 22.5 months in arm B. So if you look at, so the next subgroup was EGFR positive after EGFR TKIs. So in intention to treat population, they divided into wild type and EGFR mutation or all mutation positive patients. Total was 160. Of that, EGFR mutation were 124. Sensitizing EGFR mutation was 91. And out of those mutated patients, the number who had prior TKI therapy was 78. So in EGFR mutated or all mutated patients, the progression-free survival was better in arm B compared to arm C. There was around a difference of around 3.5 months, 3.6 months. Then overall survival benefit with sensitizing EGFR mutations, again, arm B did well compared to arm C, whereas no benefit was observed between arm A and C, which is one either eculizumab or bevacizumab plus chemotherapy. With prior TKI therapy, again, arm B did well compared to arm C. So median overall survival in B was 27.8 months, whereas that in C was 18.1 months. And with no benefit was observed between arm A versus arm C. So ORR and duration of response were improved with bevacizumab plus eculizumab plus chemotherapy in patients with EGFR positive non-small cell lung cancer. So if you look at the duration of response was 11.1 months. Median duration of response was 11.1 months in the arm B, whereas 4.7 months in arm C. And ORR rates improved from 42% in arm C compared to 71% in arm B. So the next subgroup was liver metastasis. So again, in this subgroup as well, there was clinically meaningful progression-free survival in arm B compared to arm C. So arm B, the median overall survival was definitely better than arm C. Again, arm A and C, there was no much difference. And duration of response in the subgroup, median duration of response was 10.7 months in arm B compared to arm C, which was 4.6 months. So again, apart from EGFR mutation and then liver metastasis, they also looked at patients with bulky disease. They have classified bulky disease into different types: high disease burden and low disease burden. In one subgroup, they looked at greater than equal to third quartile, which means they looked at the sum of the longest diameters of target lesions, which was greater than or equal to 108 millimeter. And the other subgroup, they looked at greater than or equal to median number of metastatic sites compared to the median number observed in the study population. So two different subgroups classified into high disease burden and low disease burden. So if you look at the subgroup with the SLD greater than or equal to third quartile high burden, again they did well with 15.5 months of median survival compared to arm C, 10.7 months. Low burden was as well, did well, but not as good as high burden disease. And it's the same with number of metastatic sites as well. So the benefit was even more pronounced in high burden disease burden subgroups, whether it was looking at the size of the lesions or number of the lesions. So coming to the toxicity profile, so there were the treatment-related adverse events grade 3, grade 4 were higher in arm B, as we would expect with 4 drugs compared to arm C. So 11 in so 3 to 4, grade 3 to 4 was around 57% in arm B compared to 49% in arm C, whereas grade 5 was 3% in arm B and 2% in arm C. But manageable side effects, and there is no point comparing the immune side effects because there was no immunotherapy in arm C. So if to summarize, IMpower 150. So both co-primary endpoints were met in this first phase 3 chemoimmunotherapy plus anti-VEGF combination study. In all comer, first-line non-squamous metastatic non-small cell carcinoma. There was clinically meaningful progression-free survival and overall survival benefits in all patients, including key clinical subgroups with EGFR and ALK mutations and liver metastasis. So benefit was also observed in patients with or without bulky disease. So further supporting using of this regimen as first-line option for patients with high burden disease. And atezolizumab in combination with chemotherapy plus bevacizumab appears to be well tolerated, and its safety profile is consistent with no safety risks. Thank you. Hello.
Thank you, Dr. Anila. So
Thank
with
you.
this, we come towards the end of the webinar. Thank you very much to all our distinguished speakers for their insightful presentations. This evening has truly been enriching, filled with valuable perspectives. We sincerely thank all our attendees for your respective participation and valuable time. Wishing everyone a pleasant evening ahead. And until we meet next, let's continue working together to advance cancer care through knowledge and collaboration. Thank you and good night.
Thank you.
Lena's good.